This is what Sonny and June gave us for Christmas this year. These are my Christmas dolls. These are my Christmas Santas I've been collecting. This was the first set I got last year. These are the Santas from different countries. I think she has a pretty face. These are the Christmas kids that Jean got from Campbell Soup. And these are my Santa Clauses that I collected this year. Still singing. They're my nutcrackers that Mother and Daddy gave me last year. And this is the one I started this year collecting. These are my different nativity sets. This is a wooden one that I bought and had to finish making. This is a little miniature set I made last year. And then this is a set that Mother started for me about 10 years ago. Susan's quilt that she got for Christmas. Boy, look in the corner. Susie.
I'll show you later after I get a bath.
What kind is it?
A Colt 22 dash. Richard Petty Tates.
Oh, yeah. The man.
The smell good stuff.
Look at that, didn't you?
Yes. The racetrack set.
Oh, yeah, you can have fun with that.
The boys.
What are your tractors?
And my tractor tires. My home tractors. John Deere.
Oh, yeah, she's
That's
cute.
John
What's her
Deere.
name?
Flora.
Flora.
Old MacDonald. On a farm.
That's cute. This is what Santa brought Susan. 3 little dreamsicles. They're cute. This is Susan's. Aha! Another watch. I love cows. And I love quilts. What Jean gave me for Christmas. It'll be tough. What is that? 32? 30? 38? Smith & Wesson. Oh yeah. It'll be tough with that one. Miles Protector. Got an Agnifox book. I got a can opener.
Specially made
A grandpappy.
for huffing it.
It's good. It sure does. That's really good. Get all that good stuff behind Mother. That's my carrot cake I cooked.
Get back.
Ready? Ready for our Christmas dinner. We can get Papa in here.
I thought he said, just
Down
not
there
really.
to eat something with them Monday night. Let's go out there.
Now look, put your ear up to the fire station right
Okay.
there.
Press it for me. Let's see what it does.
Put it up right there. It comes out.
Okay. Yeah, that's where the sound comes, isn't it? That's Sonic City. Make it sound off for me with cars.
That's another police car.
Is it?
That's the bad guy.
Well, tell me something. What did Santa Claus bring you? TJ. Talk to me and tell me what Santa Claus brought you.
I
Forget?
Give y'all. Where'd you say they were at Lowe's?
What you got, Doug? What is it? Mr. Bucket. What else did you get? Show me what you got.
Mom was trying to
No.
put this together.
Well, show me your knife. Show me your knife that Santa Claus brought you.
Yeah, I want to see that knife.
Doug,
Oh, look.
like that. That's a Rambo knife?
No,
What kind is it?
it's like Robin.
Oh, it's a Robin Hood knife.
Like
Oh, it's like Robin Hood, but it's not exactly.
Give me the instructions.
And Lisa, what are you doing?
I'm trying to put together a game that I can't figure out.
Uh-huh.
I know how.
He does that.
You're going to have to show Mama how to do it? You still playing with your game? Hmm?
Papa!
There they come, the wounded. Lord, look at the wounded.
Hey, buddy.
And look at
Hey,
there.
Doug.
Hey!
Right,
Papa!
14.
Hey, look!
What you got, bud?
Who did it for him?
Let me see that now. Ooh, what you got,
Did y'all have to wait very long?
No, he took Granny to ride on in and I did the paperwork because he was good. And then while we were there, when they started filing,
Did they?
come in with a little girl with a broke arm.
Let Papa see your knife, Doug.
You already showed it.
You showed it to him. You did.
Sold it.
The end of that. What is that thing?
Look up there, TJ's grandma.
What is it, Rick? Oh, TJ?
It's a space shuttle.
Who gave you that?
I don't know.
Granny and Granddaddy Thompson.
Go tell him thank you.
Thank you!
Don't tell me in my ear. Tell me. There you go. Look at there. Astronaut got his backpack on. He's ready to go. Shh. See there how they got the backpacks on?
That's like Cape
Fire.
Kennedy.
The red one has
What you got, Doug? Mr. Bucket. They go all over the floor, don't they?
Look, these satellite here. Look, TJ.
Listen, you're getting good at that. Time.
Hi.
Hi. Okay, now what's your name?
Manny. Amina.
Amina? And what's your name?
Manny.
Amani? What's your name?
Whoever you want to call me.
What's your name?
Whoever you want to call me.
Whatever. George?
A girl's name it has to be.
Oh, it has to be a girl's name?
Nah.
How about Mary Lou? I like Mary Lou. And your name is George?
CJ and Douglas.
Let's see. And Douglas. Oh, what you doing, TJ? You playing with Papa's track? Oh, yeah.
Jump.
Hey, it says Ahmed.
Doug.
Go back in there. Come on. Go back in there.
Hey there.
Hey, we're gonna jump for you.
Yeah, he likes to jump.
Jump.
Move,
Doug,
Doug.
Doug, do you like that baby? You want one like it? Huh? Oh, that's cute. You know what his name is? Look, hold on to him, Gene. What's his name, Doug? What's your baby's name?
Ahmed.
Ahmed.
Yeah.
Ararat.
Hey, what place?
Settle down.
This is the day after Christmas, huh, Timmy?
That's too tight. Put it in your bag.
Got him, Granny.
Where's all the
Get a
goods?
picture of him fighting. Look at it.
Get that Rambo knife, Doug. Get it after him.
He can't get it. Sweetie pie.
What's your
Put
dog's
it in your
name?
bag too.
Cutie pie.
Give me that, baby doll. Give me that.
It's my dog.
What's your dog's name?
Cutie pie.
No. Come here, Hannah. Come here, Hannah. You want to come look at my dog?
Quick.
Yeah. Yeah. Hannah. You want to come look at my dog? Wait.
I got it.
Right, you can't touch me.
I'm gonna keep
I'm gonna spin
That's
you.
my dog.
Okay. Ah, no, it's fine.
Come here, Hannah.
Grandma.
No, it's mine.
It's mine.
It's mine.
He was hanging.
Mine.
Oh.
PJ, put it back in the box.
Show.
Show her that how it works. It's a nutcracker.
Did you want to take a picture?
Oh, whose present's that?
Mine.
Yours.
Yes.
Granny Alvis, I believe. We're gonna pretend. Okay. Is that your gift?
Yeah.
Oh, good. Well, tell me what you got for Christmas.
Let me open it.
No, don't open it. No.
You got me pretend hair.
You got what?
Pretend hair.
Oh, okay.
Finger paint.
Uh-huh.
Jump rope.
Mm-hmm. Can you jump rope? Do you? That's good.
A bicycle.
Oh, do you know how to ride it?
Hmm?
You know how to ride a bicycle? That's good. Count in Arabic for me. Show me how to count.
Okay. One, name, Dati, Abba, Hamsi, Siti, Seba, Taman, Tisa, Asma.
Is that 1 through 10? That's
1, 2,
3, 4, 5.
yeah.
That's good.
Happened to the virus.
Well, sing.
Happened to the virus. Happened to I forgot it.
Stop it.
Okay, start singing.
Just over here gnawing.
Taking it in.
Wait for me.
That's what he was doing to me in the living room.
Come. Mom. Flowers. Keeping up feelings. Brother have down here. There's a banana. two times. The little good one. Next
One that
one
never
day, little beautiful.
This is the never-ending
To the flowers.
Well, what's he
Rudolph,
Rudolph.
Rudolph, the red-nosed reindeer had a really shiny nose. I know that. You would never say it glows. I love the yellow reindeer. He like a claw in lace. But Rudolph, the red-nosed reindeer.
You okay down?
What?
And one shiny. And he's
You would even say it was.
Here we go.
Yelling up.
Jingle bells, jingle bells, jingle all the way. Oh, what fun it is to ride in a one-horse open sleigh. Hey, jingle bells, jingle bells, jingle all the way. Oh, what fun it is to ride in a one-horse open sleigh. Hey, jingle bells, jingle bells, jingle all the way. Oh, what fun it is to ride in a one-horse open sleigh. Hey, jingle bells, jingle bells, jingle all the way. Oh, what fun it is to ride in a one-horse open sleigh.
Now that ain't the way you sing Santa Claus.
Come on, get up and sing it, Doug.
You pushed him first, now you stop it.
Sing, Doug. Come here, Doug.
Well, y'all to town. You girls know it?
You make it all this, you take it away. You're nice. Santa Claus is coming to town.
Y'all give him some sugar and he'll sing it. Give him some sugar, Mina. Give him a hug.
Be quiet.
Hug his neck, TJ.
Hush.
Hey, move, TJ.
Tell him to hush.
That's something.
Come on.
He's making all this. He's taking it twice. Oh, Lord, you want heaven to say you're nice.
Well, sing.
Santa Claus is coming. Oh,
Come over here, Alex.
you're sleeping and he knows when you're awake. Jingle
Get me one kiss.
Come on, sing for me.
all the way. Oh, what fun it is to ride in a one-horse open sleigh. Hey, it's a snowman. Frosty the Snowman.
This is June the 16th, 1994. TJ and Doug are waiting to go to Virginia Beach to live. We got to missing TJ, and we got to looking for him because TJ, where are you? TJ. We walked around the house looking for TJ. Where could TJ be? Well, there's Trav. Well, look. Isn't that sweet? He's asleep. Both of them asleep together. That's a good brother. Hey, Doug.
A Power Ranger book and a book sack and wings and a suit.
A suit. Let's see your book sack. Oh man, that's good. You can be cool at school with that, aren't you, buddy? It says, what does it say?
Power Rangers.
Power Rangers, yeah. You got an outfit too. Which outfit did you get?
A Mighty Morphin Power Rangers.
Okay. What are their names, Doug?
Maggie and a Foster.
What?
Maggie and Foster.
Let's see, which one's Maggie? Huh?
No.
Maggie's got the brown on her, and Foster's black.
Maggie.
They were born on April the 16th. Did you know that? They want to get out, don't they?
Come on, Foster.
You like those puppies? Keep going. They follow you everywhere you go. Which one do you like the best?
Maggie and Foster.
You like both of them? Look at that one climbing the fence. That's how he was getting out. Or she. That's Maggie, isn't it?
Maggie and Foster. Maggie. Maggie.
They like you, Doug. You just getting up, Doug? Travis? Huh?
Hey, Doug.
You just getting up from your nap?
What's in the camera? What's in the camera? What's in the camera?
Who's got you? Big brother? Huh?
What's that? What's that over there? What's that?
He's 6 months old now, TJ.
Yeah.
Half a year. How about that?
Bob, sir. Turn him loose. Yes, sir. Another jingle, Bob.
Travis. Just wait a minute. Travis. Hey, Booger.
Hello. Travis, what can you do? Did I kick me? Did I come outside? Mom.
Hey, Travis.
Mom. Hello.
Okay, TJ, don't do that.
Dad, let's go outside.
Travis. Hey, sweetie.
Let's go.
Travis. Hey, patty cake. Patty cake. Talk to Mama.
It's lunchtime. Lunchtime in New York. They're having their lunch. I was in the movie Rocky II. I played the meat. Maybe you saw me? How you doing? It's nice to see you. See this guy? Yeah, we're trying to beat him. Okay. Let's go. Which one of you guys went? Back to live in Saki?
Pronounce Seguin.
Saki, yes. Very good. So what's going on in Saki?
Well, let's see, the Texas Youth
Hey,
Radio.
Travis.
I'll bet you have.
Yeah, they're fun. Oh, they're fun. But they don't have any
Travis. Oh, wait.
Yeah, we're gonna need to eat.
Is it a blur? Is it a?
We're
it a
gonna eat
blur?
some more.
No, it's dark though. I mean, it looks dark.
He just opened his mouth to holler.
That's your used to that. Ain't you gonna give you the more? Let me see what it is. Look, yeah, little mouth. Y'all need some. I'm gonna get it. What happened?
His mouth out. Well, hit him.
The ball hit him. He's what? He's blooded.
Too far?
Come here, let me see it. Yeah.
I can't even see his hands in the way. Where's it split? Oh, he's okay.
Is that blood on your finger or did you hurt your finger? Blood.
Hey, what's the matter with you, boy?
What did the Lion King do?
Okay. Oh, you wanted me to roll a girl ball too?
What did Lion King
Susan
say?
needs to be out there.
Where's the stuff that he gets with his... Here, boy, look like a dog.
Big bird.
There, look at that.
This is TJ.
That's all he wanted.
He's already grown. He has Blake's wearing his. It's been
Now, he was
4 years.
crawling more than he
It's faster that way. That way.
Yeah.
Daddy, I'm gonna shut these blinds. And when? I'm gonna cut the light.
Quit.
Here's Gene and Charlie with a toy out here. Charlie's his cheering team. I don't even know what kind it is. I think it needs a little bit of work done on it. What kind is it? A what? 50? This is TJ's 8th birthday. Happy birthday, TJ. TJ, happy birthday. Okay, who made your cake, TJ? Bring it here, Tim. Let's see it better.
Grandma.
Wait a minute. I was trying to get the badge. How did she get the badge on there?
She just put one little dent in it. That's all.
She just put. How did she get the badge on?
She
How
just
did Grandma
stuck it
put
on
the
there.
badge?
She just stuck
She
it
just
on.
stuck it on
Isn't
there?
that cute?
Well, we might have to put it back.
I'm gonna get my camera.
Chill.
Well, why isn't it the flash?
He's going, which camera do I look at?
Well, don't tell me I don't have any more.
Hurry, he's
Put it back a little. Chip, stand up straight. Doug, take it out of your mouth. Look at me.
Put it down. Smile.
Smile. No, Chip. Smile.
Babbage.
Now take your patch off and let me take your picture. Look at me. Everybody now smile pretty. Just, Doug, move back, honey. Don't close your eyes. Wait a minute. You're not lined up like
I don't
a
need to get them tied.
Yeah, close your eyes, darling. Look.
Doug, stop doing call signs.
Check.
Don't hit that very
Are you still a fireman? Y'all like to swing?
Hey, Chrissy. Look at me. Don't do that. Y'all look at me. I go after two judge. Happy to see us.
Y'all need a little sister like that, don't you, boys? You want a sister like Christy?
Back up.
Y'all ready?
Tony,
Lisa,
back up.
let him sit at the back so I can take his picture. Sit down, TJ. Look at me, TJ.
Look at me, Mom.
Smile. Oh, come on. Look here. TJ.
Y'all start over right. Start over right.
Happy birthday to you. Happy birthday, dear TJ. Happy birthday to you.
All right. I'll fix the plates and bring.
It's April 1995. This is Travis playing with a Corvette. Hey, Travis. Can you call Papa? Travis? Say Papa? Where's Papa?
Thank you. Look at Granny. Wave at Granny. Tell her bye-bye. Tell Granny bye. Yeah. Wave at Granny. Tell her bye. Wave at Granny. There she is. Here. over
Bye-bye,
here.
Travis.
Tell Granny bye. That way. Tell her bye-bye.
Travis.
Tell Granny bye.
Bye-bye.
Tell her bye-bye.
There he is.
Trees and bushes, just a yard, you know, just trees and flowers.
You wanna walk out? This is the mailbox that Ricky made for his daddy last year. backyard. This is what Sonny gave Jean for Christmas last year. He's real proud of this. This is the azalea that we got when Mr. Ivy died. A friend gave it to us. And his number what?
TJ's 12 and Doug's 9.
I'm looking at number 11.
A shortstop. Sitting off the TV.
I want to take the right one. Oh, I had it on Doug. Oh man.
On last batter,
Mhm.
they you just run till they get you out, or either like they'll just run if there was somebody on the third
Mhm.
or anywhere. They just run home and tag home, and the person's out. Oh, good. Run, TJ, run fast, run fast. Oh. Right anyway.
Mhm.
All right, Doug. Run on, Doug. Oh, Doug, run fast. Whew.
I made it.
Look, watch TJ. See TJ? He's gonna hit the ball. Go,
Got to
TJ,
fix
go.
his clothes.
Yeah, he has to be. Come on, T. All right. Yeah. Run, T! Run on, baby!
Way to go! Way to go!
All right. All right.
Look.
Go on to second.
Don't they?
I know it. Look. Hey, look what Mommy did. It's a toy.
Where was it? I thought it was that camera.
With all them people.
Come, TJ. Oh. Good try, T. What are they talking about? Right through TJ's glove. Tag him! Tag him! the other way. All right, T.
Come on.
There's Doug.
Hmm.
There's Doug.
Doug.
Go, Doug.
Look, he cracks.
Mm-hmm. I want you to look.
Woo!
Way to go!
Run, Doug! All right. Well, that was a good hit.
That chair.
That wasn't. That was a good hit for Doug.
Sure was. That's a hard hit.
See, Doug? See, Doug got this one? Run, Michael! Run hard, Doug! Come on, Doug. I think you're going to get him coming in this time.
Go, Doug!
Run, Doug! Run, Michael! Yes.
Good.
Right.
Great.
I'm going to sit here and let it get hot.
Changing bats on that little pole.
I know.
There
All
you
right.
go. His hat's too big.
Yeah, try to.
Okay, fix
Okay,
that
TJ,
suit.
yeah. He was upset he couldn't find his back glove.
Oh, really?
That makes him hit better. Run, TJ! Well, they were all over him. He didn't have a chance. Good hit, T! Michael! Oh,
Well, he
right.
hit
He
it.
hit it. He sure did.
Look.
Run, run, run! Yes! Woo! David! Run on, T! TJ's coming home. Move, T!
Great, way to go.
All right.
TJ's on first.
Yeah. I'm gonna leave this drink here.
Okay.
You go see Papa? I'm gonna leave this here too. Here, let's take you. You wanna take your cup?
Way to go, Doug. Good, TJ. Way to go, Doug. Good, Doug.
Go, Doug. All right, we got 2 runs that time. See, Doug?
Oh, he knocked, and 2 came in?
Yeah, 2 came in that time.
Doug! Who wanna look? TJ, look over here at me.
Yeah. Look, there's Doug. Hey, Doug. Run, Doug! Run, Doug! All right.
Good. He's on 3rd, isn't he?
Yeah. TJ's up after this one.
I can't get him to look at me.
Look, see that ball? Watch him. Now hit that ball. Hit it. Watch him hit the ball. Yeah. Good pup.
Look at Doug.
Oh.
Go, Doug.
Run! Yeah, look. right.
That's good.
Okay, TJ's up next after this one. I thought he was up next. He's up at the end. Look, tell Ariel. Hit the ball.
Okay, TJ.
Come on, TJ.
Good
Oh,
hit.
not a pop ball.
Did they catch it?
Good hit, TJ. Way to end the game. Pop ball.
Who won?
I believe him. What's the name of the team?
Rangers.
We were getting slaughtered. I don't think it was, maybe not too bad.
I think we got at least 5 runs in. So.
Now I know your team won. I don't know what's going on.
Good. We got. Hey, Rangers. Doug!
Doug going to the wrong one. Isn't
Doug's up there fussing, saying, we won. We won. He fussed anybody. Doug got there in time for him to break.
We began to go backward, and so the race movies no longer are doing their job.
White producers began to dominate the race movie market. Harry M. Popkin produced the movie The Duke is Tops, in which Lena Horne made her movie debut in a supporting role.
I know you remember all I told you. We'll see our dreams through. You remember.
Once Hollywood noticed her, the movie was re-released as The Bronze Venus, and Lena Horne got top billing. The difference between race movies and all-black cast Hollywood films began to fade. But popular vocalist Herb Jeffries was one of those who recognized that there was still a need for race movies.
There's only one shot left. Well, I was with Earl Hines' band as a vocalist with his band.
Flamingo.
We were traveling on the road. It was in Cincinnati, Ohio. It was an early evening, about 5 o'clock, and there were a bunch of children running up the alleyway. Group of little white children and one little black child running along behind, and he was crying. They went through the fence, and so we called him over and says, hey, what's the matter? Those guys hit you? And he said, no, they're my friends. I said, your friends? What are you crying about? He said, well, we're playing cowboy, and I want to be Tom Mix, and they won't let me be Tom Mix because Tom Mix ain't black. And, boy, the guys in the band were really set back by that, and we talked about it and said, gee, you know, little black children cannot relate in a cowboy picture. Who can they be, you see? And yet there were many great black cowboys, great heroes in our history. So I came back to Hollywood, decided that I was going to come out here and somehow instigate a black cowboy picture that could play in thousands and thousands of segregated black theaters throughout the South. I said, I gotta make that cowboy picture somehow.
Jeffries went on to become the first black singing cowboy.
Now I am confessing, got that gambling craze. Will I learn my lesson? Oh, I'll be broke for 30 days. I can't trust at the store.
Jeffries' films were widely distributed, but by the late 30s, Hollywood had begun to siphon off the race movie audience as they controlled more and more theaters.
After we made all these pictures, we had no place to show them. We went around these different places trying to show all these pictures. We had no place to show them.
Forced to adapt to a shrinking market, Oscar Micheaux began making gangster films and mystery thrillers like Murder in Harlem. He even came from behind the camera to play a bit part as a detective.
That tall Negro did this. He will try to lay it on the knife.
Oscar Micheaux, he did everything fast, quickie, because his money was limited. He didn't have any money. But everybody just went along with him because they wanted to be in the pictures, you know, so they just went along with it.
How in the world did we ever do it? But we were able to shoot from early in the morning, daybreak, and sometimes until 1 o'clock at night we were still filming. And sometimes I slept on the set. You know, I'd crawl up on a army bunk that they'd unfold and put there, and then I'd just lay down with all my clothes on, all the cowboy clothes on, and except my hat, and that's one of the few times I took it off, and wake up in the morning, and the guys wake up and say, okay, we're going to get out there and do a chase shot, and we'd go do it.
While black westerns portrayed a romantic view of life, Micheaux's films continued to scold, presenting a vision that was both critical and disturbing.
Why is it that so many, most all of our men, when they go into business, it's got to be a crap game, a numbers bank, or a policy shop? Why can't they go into some kind of legitimate business like white people?
They could, but they've made no study of economics. Their idea of success is to seek the line of least resistance. The Negro hates to think. He's a stranger to planning.
I guess you're right.
I guess I think too much, and plan too much also. But after viewing the failure of our group, for we are failures, it seems that we should go right back to the beginning and start all over again. That's what I decided to do.
Mm-hmm.
I'm going to buy a farm and start at the beginning.
With God's Stepchildren, it became clear that Micheaux was out of touch with a new generation of moviegoers. Micheaux was also accused of ridiculing dark-skinned Negroes.
Oh, Mama, look. Who is that, Miss Jimmy? Oh, what makes him so funny looking?
That's Clyde Wade, Jimmy's friend, who we want you to meet.
You mean that? That's the man he's been talking about?
Sure.
And he wants you to like that? That person? Oh, Mama, I don't want anybody who looks like that. Oh,
In some cities, black protesters even forced him to withdraw the film.
Might hear you.
By the 40s, it was clear the type of race movies Oscar Micheaux was famous for no longer had a future. Oscar Micheaux tried to make a comeback. After the war, he came out of retirement to make The Betrayal. In this film, he resurrected the same story of an interracial romance saved by one drop of black blood. New York critics panned the film. On Broadway, the movie closed within days. But at local theaters, black audiences stood in line to see it. In 1951, while on the road trying to promote his movies, Oscar Micheaux died. In a career that spanned 30 years, Oscar Micheaux produced more than 40 motion pictures. By the early 50s, race movies had all but disappeared.
And then we began to find that integration became quite prevalent. The black theaters were no longer needed because we integrated and people were going any theater they wanted to go to. So that was the end of the black motion picture business.
Today, only a few fragments of these films survive. Reminders of a time when movie makers struggled to fill the hunger black Americans had to see themselves portrayed with dignity, affection, and pride.
The existence of a body of films from that period is proof that we were there. That certain kinds of assaults, such as Birth of a Nation, did not go unanswered. That the explanation industry was challenged. And that there was a movement in those days to try to do justice to black character and to community life. It gives us memories. It gives us a sense of the past. And it puts a bone in the back.
A production of WGBH Boston. Major funding for this series is provided by the Corporation for Public Broadcasting and by the annual financial support from viewers like you.
The American Experience was made possible by generations of Americans. Funding for this program was made possible by American Express.
And by Miracle Grow plant food. For flowers, for vegetables, whatever you grow, a gardener's true friend is Miracle Grow.
You can purchase the American Experience program you have just seen on home video cassette for $19.95, plus shipping and handling. To order, call 1-800-255-9424.
This is PBS.
For a transcript of this program, send $5 to Journal Graphics, 1535 Grant Street, Denver, Colorado, 80203, or call 303-831-9000.
This is SCETV, television that teaches and inspires.
There's even more to South Carolina ETV than McNeil-Lehrer. For example, ETV's teleconferencing service trained 20,000 poll workers who will serve 80% of South Carolina's voters on Election Day.
From the creators of Northern Exposure comes a story of two families.
I'm raising 3 children.
Families brought together by their love.
This is to you, Lily.
And torn apart by their times.
I want my family left alone!
Share their courage and their hope.
Things are changing, Papa.
I'll fly away.
Next time on Austin City Limits, the best of New Orleans with Zachary Richard. And the Dirty Dozen Brass Band.
Herbert Armstrong is a respected man.
You disgust me.
An upstanding citizen.
Bloody Marvin.
And a shrewd businessman.
His affability covers a multitude of sins. The laziest professional man I've ever had dealings with.
But Herbert has two rather annoying problems.
Herbert! Herbert! Herbert!
And one solution.
Yes, I'd like to buy some arsenic. I won't ever put another sign.
It does seem to be for the best, Herbert.
You see a new man before you. You are wicked.
You made the common mistake of presuming that once a patient enters this place, he or she will never leave it except in a box. That's not the case. Not the case at all.
Oh, she'll make a full recovery then.
I rather think she might.
Just need a little more arsenic for the garden. Very effective indeed, very effective. Didn't take quite enough.
Sarah Miles and Michael Kitchen star.
Well.
In Dandelion Dead on Masterpiece Theater.
Next time on Nova.
I'm so excited!
Ruth Pointer, nearing menopause, gives birth to twins. Aileen Lee, at 21, finds herself unexpectedly in menopause. Science now offers these women options never before available. But are they right for everyone?
It doesn't hit you that she's going through menopause. It just hits you that she's just being a pain in the neck.
What's new about menopause? Next time on Nova.
This is WJPM-TV, Channel 33, Florence, South Carolina.
Health in Our Hands is made possible by the W.K. Kellogg Foundation.
Can you talk to your physician? Do you say what you really feel? And what do you do when you and your healthcare provider don't see eye to eye? Answers coming up on Health in Our Hands.
My doctor tells me I can live to be 100.
You know, it tears me up inside to see her so sick.
It was the most amazing experience of my life. I kept having these horrible headaches.
I've learned kind to myself.
Hi, I'm Karen Stone. This episode of Health in Our Hands is about finding healthcare providers who are not only competent, but who listen and understand our needs. As most of us know, that can be hard. Sometimes that's because we don't express our needs well. Things fly out of our heads when we're in pain or afraid. Sometimes it's because we don't have a provider who is just right for us. This show is about asking questions, getting answers, and speaking up. We plan to tell you some personal stories and give you some useful and usable information. You just might want to jot down some notes. Later on, we'll look at how one managed health care plan is helping its members make decisions about who should look after them.
Well, I'd be more than happy to be your primary care doctor.
Then, in our Making Choices segment, our co-host, Dr. Frida Lewis Hall, will help us thread our way through the communication jungle.
What should you do when you're convinced that this is not the right provider for you?
But first, we're going to hear a personal story that raises some key questions we've all asked ourselves. What should I do if I'm not comfortable with my provider? What happens when I don't express exactly how I feel? Or when I do? Like many women, Susan Lucas, a social worker and psychotherapist, has sometimes had a problem finding the right physician for herself, competent and understanding.
For me, there are two things. There's the medical problem to deal with, and then there's the anxiety about the medical problem to deal with. I want somebody who addresses both. And I remember a very long time ago when I was in my 20s going to a doctor for a minor procedure on my arm, and I had to lie on the table, and he was about to start this procedure, and I put my head up, and he said, "Get your head out of the way." And I said to him, I could feel the color rising in myself, and it was really the first time I ever talked back to a doctor, and I said to him, "Listen, that's my arm." And I remember how upset I was that I had to do that, but it changed my attitude about doctors, and I thought, there's somebody else who knows how to do this procedure just as well as this guy does, who's a good doctor in the sense that he doesn't treat people that way.
About a year ago, Lucas became frightened because literally overnight, the hearing in her left ear started to go. Her regular physician wasn't available, so she went to a new one.
And I had an examination, and at the end of the examination expressed, I thought pretty clearly, my concern about this. I said, I make my living listening, and I'm very frightened by this. And he said to me, "Oh, don't worry. If things don't work out, you can always get a hearing aid, and you'll be able to hear your patients." Not the answer I needed to hear. And I left there feeling still probably more scared to death than I was before. And in addition to that, as if I didn't have somebody to turn to who I could count on to give me information of the sort that I needed at that moment. And I felt bereft, I think, quite uncertain what to do next and scared.
So what did happen next? You obviously were not satisfied with this doctor's attitude and even perhaps his diagnosis. What did you do?
When it recurred about 6 months later, I contacted my regular, by then, medical doctor. I had always had specialists if I needed them, but I'd never had a doctor. And I finally found one that I trusted, and she sent me to somebody who was very direct and said, "Look, this is what it is, this is what it isn't. It's going to come and go. It's not serious. You'll never lose your hearing. You won't lose your hearing in your other ear." Boom, 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 boom.
As you look over your past experiences with doctors, trying to find good ones where you're comfortable, have you always told doctors precisely what your symptoms are?
I think I'm pretty good at describing my symptoms. What I suspect I'm not terribly good at, or not as good as I should be, which may be something that everybody feels, I don't know, is that I'm not sure I always transmit how anxious I feel about a condition that I go to a doctor for. That I may give the impression that I'm calmer about things than I actually am. So I think maybe I wasn't as good at certain times as I could have been at saying, "Listen, I'm really worried about this," or "I'm really scared." I guess I go on the assumption that doctors ought to know that.
You've mentioned one or several bad experiences with male doctors. You mentioned you found several doctors you like very much who are female. You have several daughters. What do you tell them when they have medical problems? Avoid male physicians?
No, absolutely not. No, in fact, the doctor who resolved this hearing issue for me was a male doctor. I have never, I don't think, consciously thought I have to find female doctors I'd feel more comfortable with them. In fact, I do think I've impressed on them that their openness as a patient is important. Their ability to tell their doctor what they're feeling and what they think they need and what they think is wrong with them, and have the doctor hear it. I hope I'm getting there, but you can never be sure.
When we come back, some ways to think about getting the care you deserve and how to communicate. Susan Lucas told us that by asking friends and colleagues, she finally found a competent physician who also gave her the right level of comfort. Some of us are lucky. We find a healthcare provider we're comfortable with right away and stick with him or her over the years. Others find it more difficult or aren't so lucky. It takes research, the experts say. First, think about your medical needs. Then, focus on competence, convenience, and hours. Finally, do the work. At the Columbia University School of Nursing, we heard some more about this from Dr. Donna Gaffney, a professor of nursing and a psychotherapist.
In terms of finding a provider that is a really good match for what your needs are and your personality and who you feel comfortable with, the best thing to do is begin to do some research on who your providers are, what your options are in terms of where they have their offices, what kinds of hours they have, and then to talk to people who already use those providers, to call them up, to talk to the personnel who work in the office and ask them questions about how long waiting times are, how often they have hours every week, are they in practice with anyone else.
Gaffney says it's worth the effort.
We put all kinds of work into other parts of our lives, getting estimates for painting rooms, looking at different furniture stores and interviewing people, teachers and babysitters. This is the most important thing that you'll ever have to do in your life, and that's to take care of yourself. So why not find someone that you feel that you can be a partner with?
In these new days of managed care and health maintenance organizations, when our list of available providers might be limited, it's all the more important to make savvy decisions, to be good healthcare consumers. Some managed care organizations are taking steps to help ease the way.
One such HMO is the Kaiser Foundation Health Plan in White Plains, New York. Nationwide, they're the biggest of the HMOs, with over 6 million members. Here, Kaiser has 29,000 members. Like all HMOs, those members pay a set fee up front for all their care. And like most HMOs, Kaiser is a self-contained medical unit with a group of physicians who work exclusively for it. There's a pharmacy, a lab, where blood and urine specimens are obtained, optical, surgical, and other specialties. All have space and providers within the building. The biggest department is internal medicine. It's here that members meet their primary care providers.
It's a funny chart to look at because it starts when you were 2 years old, which is kind of fun, and you were healthy, and then you were healthy at 5 and 8 and 12 and a half. Do you remember a knee injury when you were 8 years old?
Yes.
You do?
Yes, I do, because it hurt very badly.
Jennifer Kelly came in today for a routine physical before going off to college. Because she has just turned 18, she's outgrown the pediatrics department. So she is given an appointment with the first physician available in internal medicine, Dr. Susan Flansman. She gets the typical examination and the usual questions.
I know, that doesn't tickle. Do you, here's the biggie, smoke?
No.
All right. Good. How about alcohol? Not at all? Not even socially? And marijuana, cocaine, heroin?
Nope.
No drug use?
Never tried it.
Okay. Are you sexually active?
Yes.
Okay, what kind of birth control do you use?
Condom.
I know these are awkward questions, but have you had a lot of partners in your life? So who is serving as your doctor?
Right now, I just came in for the physical, so I have to get set up with a doctor.
Okay. Well, I'd be more than happy to be your primary care doctor. It's very important, as it was in pediatrics, that you choose somebody, and that way we get to know you and we can kind of keep track of things as...
She made me feel like I came to see her, not just came to see a doctor, but came in to see her. If I had any problems with anything that had to do with me personally, I would tell her. I'd feel comfortable telling her. And a lot of times, that's what you need. You need to be able to tell them that.
Not all choices of a primary care physician are as easy, nor as casual as that made by Jennifer. In fact, Kaiser has a system to help members be good consumers. Early on, they meet with a nurse advisor. Here, it's Robin Cohen.
10 years ago, I was diagnosed with breast cancer, and I had a mastectomy, and I had 6 months of chemotherapy. I have a little swelling in one of my arms, but other than that, I feel I'm fully recovered.
You said you had chemotherapy for 6 months. Did that affect your...
The purpose of these interviews is to find out what special needs the member has and to help choose a primary care physician.
I'm really looking for a provider that's somewhere around my age, somebody who really has a history and an interest in breast cancer and prevention and in women's health. And I've heard that Dr. Thompson...
Dr. Carolyn Thompson has been here 6 years.
Some people are very traditional and want an older male physician feel more comfortable there. Other people want, women especially these days seem to want female physicians that they can identify with. In many cases, people come in knowing other people who are here at Kaiser and have seen a number of physicians for physicals or for routine care or for emergency care, and can make recommendations, just like in the community. People say, oh, yes, I've seen that doctor, I like them, etc. You need to make an appointment to meet a physician, whether it be for a physical or if you have an ongoing health problem such as high blood pressure or diabetes. You need to make a first contact and then decide whether or not that's someone that you feel comfortable with.
First thing people want to know is about your training. In other words, where did you go to medical school? Where did you do your residency or internship? And do you have some sort of subspecialty interest?
Dr. Richard Petrucci is also in the internal medicine department.
You have to be able to communicate with the patient, and they have to be able to communicate with you. You know, for example, they may be having a problem that may be awkward for them to talk about. And if there's a good fit there and a good rapport, they can feel comfortable sitting down with you in your office discussing it, even if it's something that may embarrass them or they really don't want to talk about.
I think patients are looking for that. They want somebody who's going to talk to them, who's going to listen to them, who's going to be concerned about them, who's going to look at them as a patient and not a number. That's important.
You're talking about my health, and I want to know what's going on. I mean, regardless of whether I'm with you for 10 minutes or can you take the time to be with me for 20 minutes to explain what's going on.
Longtime Kaiser member Cheryl Harper likes her physicians here. Before, it wasn't so good.
I was also seeing an old general practitioner who my great-grandmother went to see. He was a male, and I mean, he was from the old school, and no matter what you had, he always gave you the same prescription for the same thing. So I really didn't go to him that often, only if it was dire emergency.
What if patients don't like the personality or the medical philosophy of their primary care provider?
When I speak to a patient and they say to me that they want to change, fine, I put it in the computer, they're changed, and I say, fine, we'll get you an appointment with who you'd like to see.
And that doesn't seem to bother the doctors.
We have many people that have seen multiple physicians, and no one feels upset about it. It's the patient's right to change physicians, and the healthcare delivery is completely unchanged by the patient's decision to do that.
My personality isn't the perfect fit for everyone. You know, that's basically life, and I don't take it as an insult. You shouldn't or you can't, just because that's how life is.
I think we really have to try to give people the choice and understand that, you know, they don't have to like me, and they can try to find someone else that they feel more comfortable with. That's not going to hurt my feelings.
It's evident that many physicians do listen, do understand, and realize how important good communication is. In fact, in and out of managed care systems, whether choosing a new acupuncturist, dentist, or physician, professionals say that the right fit is important. And change is nothing to be embarrassed or feel guilty about. Once again, Donna Gaffney of the Columbia University School of Nursing.
It's an interesting phenomena that we feel that if we don't like a healthcare provider, we're making a judgment on them, when in fact we're not making a judgment. We're saying, I don't feel comfortable with this person. This person is not meeting my needs. I need to find someone else who's going to meet me where I need to be, who can answer the questions, who can tolerate my calling every other day if I'm in the middle of a crisis. And that's the part that's really important.
And now, some other health information that you might find useful. According to a recent Gallup poll, 42% of all American women do not have annual gynecological exams. Why? The poll says many don't feel the exams are necessary. The American College of Obstetricians and Gynecologists, however, says that an annual gynecological exam is essential. It's the best way to detect and treat some of the diseases women are especially prone to, like breast and uterine cancer. On another matter, major diseases. The leading cause of death in women is heart disease. 1 in every 2 American women will suffer from it during her lifetime. After that, cancer is the next cause of death in women. First, lung cancer, then breast cancer, and third, colon cancer. 1 in 17 women will suffer from that disease. There is some good news about colon cancer. The National Institutes of Health says it's on the decline, thanks to increased and more sensitive detection tests and improved lifestyle changes. On STDs, a recent development on the research front. A group at Boston University Medical Center has found that Pap tests can also detect chlamydia, the sexually transmitted disease that affects an estimated 4 million men and women every year. If not treated, chlamydia can cause serious health problems for women: inflammation of the cervix, infertility, and complications during pregnancy. Finally, an interesting note on women's health in general. The Centers for Disease Control and Prevention in Atlanta has opened an office on women's health. The office is in response to years of criticism that women's health issues have been ignored and underfunded. The CDC office, by the way, joins those at the Public Health Service, the Food and Drug Administration, and the National Institutes of Health. Now that's progress. And now it's time for Making Choices with our co-host, Dr. Frida Lewis Hall.
If finding and choosing your healthcare provider is one half of the formula for good health care, then communicating with that provider is the other half. The world of medicine is like a foreign land with different rules, different behaviors, and a different language. I know, as a physician and psychiatrist, I'm a part of that world. It sometimes would be helpful to prepare to travel into this land just as you would any other new and different place. I'm here with Donna Gaffney. Thank you for joining us.
Thank you, Frida.
Now, earlier, you helped us figure out exactly what it was we needed to do to find a healthcare provider. Now, what about communicating with the healthcare provider?
People have their own styles in terms of, there are some people who memorize and say, and I have 4 things to tell my doctor this morning, and those things are. Other people bring a list with them. There's nothing wrong with writing things down when you go to see your healthcare provider. There's nothing wrong with writing things down while you're talking to your healthcare provider. Very often we get in a situation, we become a bit more anxious than we usually are, we forget something. It's very common to walk out of the office and say, I forgot to talk about such and such. So writing things down on a piece of paper in a notebook, whatever you're comfortable with, is very appropriate. It's interesting because I've worked with some providers who've said, now you said you came in with 4 things, we're up to 3, what's the 4th one? And very often your provider will prompt you in helping to remember that kind of thing.
In addition to the information about your symptoms and the new things that are happening to you, what about old information that you might need to take to your doctors?
I think it's really important to bring your entire history from, for women, from girlhood on, your menstrual history, reproductive history, any history in your family in terms of osteoporosis or breast cancer, other kinds of illnesses, chronic illnesses, short-term illnesses, surgical experiences, broken bones. All of that is important information that your provider really needs to have in order to make a comprehensive, accurate diagnosis. And you're really partners in the experience. And your assessment is only as good as the information that you can provide.
This sounds like a lot of work, and I know that many women are thinking or may even be saying, you know, why should I do all of this? They're the experts. Shouldn't they be doing this?
Your provider is the expert on healthcare in general, and the woman is the expert on her own body. And because of that, you really need to bring your own history and own your history. And it is a lot of work. It's a lot of work the first time you write it down. But when you update it, it's really very comforting to know that you don't have to search your memory every time, that it's a piece of paper, a file that you can just pull out and refer to.
You've done all the work. You have a good history, and you think you've done a fairly good job of importing that history to your provider, but something doesn't feel quite right. Are there any special signs that someone should look for that perhaps this is not the relationship for them?
If we come away from that visit feeling more anxious, more frightened, as Susan Lucas said in the interview in the beginning of the program, that she was scared, and she didn't expect to feel scared after her visit with her provider. So if when you come away you feel not as good as you thought you were going to, or feel worse than when you went in, then it's time to really take a look at what happened during that visit with your provider. Sometimes it's a sense throughout the entire session that you're just not being heard. And then it's important to go back and say to your provider, there's a sense, I'm getting the feeling that maybe you're not hearing me, and it's really important for me to be listened to. And I need to hear you say certain things to me, and I need to know that it's okay for me to talk to you.
I think another important thing for patients to consider are their expectations when they go in, whether or not they've gone into an office with unrealistic expectations, or if they have some deep personal preferences that are just beyond the control of the provider. I really counted on having a woman and it was a man. Differences in language, in race, and culture may actually impact how people feel about their providers. So let's say that all these things have been considered and you believe that you've made a good assessment of that and a really good try. Then what? What should you do when you're convinced that this is not the right provider for you?
If you decide to stay with a provider or to move on to someone else, the most important thing in either case is to communicate to the provider what is going on rather than just disappearing from this person's practice. To give that person an opportunity to respond to you with your needs clearly stated. So to make another appointment and to sit down and say, you know, I saw you last week and I just need to tell you that I'm uncomfortable with some of the things that happen. I like to know exactly what's going on. I want you to communicate to me. I want you to listen to what I have to say. And if that's not going to work, then I think I need to go to someone else.
We've talked about this service providing, communicating, and education as though we've had all the time in the world to do this finding, choosing, and communicating. What about when a crisis occurs?
When there's a crisis situation, it may be something that you weren't worried about before, and then the physician or the practitioner tells you, we have a big problem here. Your anxiety skyrockets, and it's very difficult to listen to information. That's why it's very important to write things down so that you can remember. You always have time, some degree of time, to make a phone call, to say, who else can I talk to about this? Do you think we need to speak with anyone else? Do I need another opinion? Sometimes time may be less than an hour. Sometimes you might have a few days. You do have some time to just even ask more questions. Tell me the pros and cons. What will happen if I don't do this? What will happen if I do it? Tell me the sequence of events. Is there anyone else who's been through the same situation?
Summing up Donna Gaffney's points, 1. Make a list of important items to discuss with your provider. 2. Take notes during your visits. 3. Know your own medical history and share it with your provider. 4. If you're unhappy with your communication or the treatment you're getting, say so. 5. Be honest with yourself and your provider about your expectations and needs. One more note. Donna Gaffney suggested that if you're really anxious or think you might be, take a friend or a relative to your appointments. Then, when you're back home, compare notes. They may remember things you forgot or didn't hear. That's it for this episode. As you know better than anyone, finding and communicating with an appropriate health care provider is tricky. Getting good care is the goal. With that in mind, what we've tried to do is give some hints and some information that should make it easier for all women to get that care. If we've done that, we'd like to hear from you. If you need more information, we'd like to know that too. Look for an address at the end of this program. For now, for Dr. Frida Lewis Hall and myself, Karen Stone, thanks for watching. Write to us at Health in Our Hands, 356 West 58th Street, New York, New York, 10019.
Health in Our Hands is made possible by the W.K. Kellogg Foundation. For a transcript of Health in Our Hands, send $5 to Journal Graphics, 1535 Grant Street, Denver, Colorado, 80203. Or to order by credit card, call 1-800-ALL-NEWS. Please specify...
This is SCETV, television that teaches and inspires.
there's even more to South Carolina ETV than McNeil Lehrer. For example, ETV's teleconferencing service trained 20,000 poll workers who will serve 80% of South Carolina's voters on Election Day.
While I was actually being abused, it was very frightening.
It's only recently that the medical profession has begun to understand that women's health care concerns are not always the same as men's. And understanding these differences is crucial if we're going to provide good health care for women.
From the creators of Northern Exposure comes a story of two families.
I'm raising 3 children.
Families brought together by their love.
This is to you, Lily.
And torn apart by their times.
I want my family left alone!
Share their courage and their hope.
Things are changing, Papa.
I'll fly away.
Next time on Austin City Limits, the best of New Orleans with Zachary Richard. And the Dirty Dozen Brass Band.
We're all fascinated by the future.
On the next episode, Mapping the Universe.
This desire to have an accurate picture of the wider universe is older than human history.
This season, Think Twice is the game on PBS.
#1! There you go! He tried to milk me for everything that he could get.
So tune in. You'll never have to think twice about watching us again.
This is WJPM-TV, Channel 33, Florence, South Carolina.
Health in Our Hands is made possible by the W.K. Kellogg Foundation.
Are you pregnant or thinking about having a baby? Do you know about the changes going on in healthcare for pregnant women? More information coming up on Health in Our Hands.
My doctor tells me I could live to be 100.
You know, it tears me up inside to see her so sick.
It was the most amazing experience of my life. I kept having these horrible headaches.
I'm very kind to myself.
Hi, I'm Karen Stone. In this episode of Health in Our Hands, we're going to look at some of the needs pregnant women have, some of the problems we hope they won't have, and some of the options available for health care. Later in this program, Dr. Frida Lewis Hall, our co-host, will help us think about these options.
What if I start out low risk and end up high risk? What happens to me?
We'll also meet two families using two very different settings and very different kinds of providers for childbirth. But first, a personal story that brings up important issues about pregnancy. Delilah Amelbear had a dangerous second pregnancy. In her 6 months, she began to swell way beyond what is normal, and her blood pressure soared. She had to have an emergency cesarean section, and the baby Priscilla was born prematurely at 2 pounds. Mother and baby are in good shape now, but life was harrowing for a while.
It got so bad that it was like people didn't really recognize me. My hands were so swollen that I had difficulty typing at the job. My legs were very swollen. I was wearing a size 8.5 shoe, which I normally wear size 7, and they were tight. My skin was actually overlapping my shoes. That's how swollen I was. And I had went to the doctor. My blood pressure was a little high. And, you know, he told me to take it easy and, you know, if there was any stress, you know, to try to eliminate it. But that was difficult to do. I was moving into a new home. I didn't want my son to miss out and transfer to a new school, so I was driving him to school back where we used to live, and then I was driving, you know, to work, and sometimes I take the train in. My job was giving me a lot of stress because I was swelling. I was no longer performing like I was performing at the job.
And your boss even complained that you were typing too slowly, right?
Oh, yes. Yes, they actually wrote me up.
So finally you landed in the hospital. Tell me how that came about.
My husband kept pushing me to call the doctor. So I called and I told my doctor, I said, listen, I need to see you. I feel like I have the disease elephantitis, you know, in my legs because, you know, it's so bad. And he told me to come in right away. He says, I want you to come to my office right now. And I did. I got in the car and I drove to his office. And when I had gotten there, he took my blood pressure right away. And I didn't really know much about blood pressure. I always felt that that was something old people had, you know, high blood pressure. What does that really do? He told me at that point, I'm admitting you in the hospital right away, and I want you to call your husband and have him pick you up. And I was like, no, I'll drive myself. You know, I could get there, I have the car. He says, no, you call him right now. So I called him, and I waited for him to come. Got there, I had all these nurses jumping on me. Where have you been? You've been gone for almost an hour and a half. You were supposed to be here. I mean, they were frantic, and I was like, oh, my God, they were yelling at me, you know? And my husband, they told him, do you know that this woman has 170 over 110? I mean, you know how ill she is? And they just, you know, like, plopped me down on the bed, and I had all these people around me, and they had me in the ICU. That's when I knew at that point, you know, this is serious. Yeah.
And when they told you we're going to have to do a C-section, what was your reaction?
Oh, my goodness. I didn't want them to take the baby out because, you know, my concern was the baby, not me. It was the baby. It was always the baby. What was going to happen? And the doctor looked at me and he said to me, the baby's not the issue anymore. You're the issue.
How did you get through it? I mean, as you look back now.
I don't know. I guess my faith in God, you know. I kept praying to him that please, you know, to save this baby. I wanted this baby so much. And just, you know, let me be okay too. So that was, and it did.
Yeah. How is Priscilla today?
Priscilla is great. She was breathing on her own after 24 hours. I mean, it was a miracle. No one could believe how well she was doing at being born at 2 pounds.
You mentioned the doctors and the medical team. You had all sorts of support around you.
Excellent. My physician and the attending physicians, I mean, they were just excellent. The neonatologists, they constantly explained things to me. I had the head doctors coming in to look at me. If it wasn't for them, I don't know if Priscilla would have survived. I don't know how I would have come out of it.
If you get pregnant again, if I decide to have another child, what would you do differently?
I would listen to my body. You know, my body was giving me lots of messages. I was driving to work one day, and I thought I was going to faint in the middle of the highway. I was so tired. And I kept ignoring my body. I just kept pushing myself.
I think that's what a lot of us face when we're pregnant. I mean, I certainly didn't know until I was pregnant that even if you have a normal, healthy pregnancy, your body's undergoing tremendous change. You're facing all sorts of different feelings and stresses that you can't imagine. And you do have to, I think, push.
I didn't want to be looked at as a wimpy, pregnant woman, you know. Oh, you know, she's just, oh, she's exaggerating because she's pregnant. I didn't want that, you know. And I knew my family needed me. So I just had to continue to push myself.
Delilah, could others around you, your caregivers, have provided more to you, more information that might have prevented this from getting to a crisis?
Yes. I think if I would have been more educated on exactly the complications that can develop in pregnancy and the signs to look for and what needs to be done. And just someone to sit down and really talk to me and say, you know, you really need to take care of yourself. I think I would have felt better because then I wasn't saying it, someone else was saying it.
Thankfully, Delilah Amelbert's experience was out of the ordinary. Few pregnant women encounter such catastrophic events. Still, care and attention are important throughout all pregnancies, beginning with decisions about your provider and where you want to give birth, which is what we'll look at next. First, we'll examine a widespread phenomenon. The old-style delivery room is being replaced. Second, we'll look at the growing use of midwives, which is not very widespread, but is having an impact in and out of hospitals. But first, the changes in maternity units.
Hi, Ruth. How are you? Hi, Ruth. Oh, I got to see my baby. Oh.
Yesterday, Marianne and Donald Herman had their first child, Nicole Marie. At first, the doctors were worried about some respiratory distress and the child's limp behavior. But after 24 hours, the team decided she was fine.
That's all right. Now that the baby's out of special care nurseries, they just transferred her into the regular nursery. She hasn't been in there yet because I won't let her out of my room. In fact, they just came. They wanted to get some vital signs, and they wanted to see if they could feed her down there, and I said, absolutely not. I'll do all that here. And, you know, if I need them, I know where they are. They're just right up the hall. I have no problem with getting them, but I really want to spend the time with my daughter. We're so lucky. She looks exactly like you, exactly.
This hospital could have handled almost any medical emergency that occurred during Marianne's labor or Nicole Marie's birth. Safety was important to the Hermans. They also wanted a hospital that could honor their personal wishes. Over the past decade, many U.S. hospitals have worked to respond to families' preferences. This is a traditional labor room with the adjacent delivery room. According to the American Hospital Association, over 60% of U.S. hospitals, like the Robert Wood Johnson University Hospital in New Brunswick, New Jersey, have given up these traditional facilities and built something quite different. Here, operating suites are on one side of the area, available for cesarean sections and childbirth emergencies. But on the other side are new so-called LDRs, where women labor, deliver, and recover after childbirth without moving from room to room. Hospital routines are more relaxed in here, and families can be present. Joanne McCullion is a nursing supervisor on the unit.
I think the biggest difference is just the comfort of the room as opposed to being whisked off to a sterile delivery room. And that can be a very frightening experience. Again, seeing both systems in play, I think that this is much more relaxed, much less frightening for the patient to have to be taken off her bed to a stretcher, to a sterile delivery room, at probably the most difficult time during labor when the baby is just about ready to be born.
Changes like these are driven by the market, says Dr. Robert Nuppel, Chief of Obstetrics and Gynecology here.
I think the hospitals have responded to the requests of the patients. As demonstrated in hospitals like this, they've developed a very home-like environment. They're trying to determine that there should be less intensity of technology, if possible and appropriate, and the setting is much more comfortable than it ever was during the 70s.
Another reason that providers are enthusiastic about LDRs is because they don't compromise safety. Technological support is still available as needed. As the physicians and nurses want a piece of equipment, they open a cabinet. Inside are such items as fetal and maternal monitoring computers, an electrocardiogram machine, a warmer and other equipment for the newborn, and instruments for a vaginal delivery.
I think the other thing that's really important is the support that is available now as opposed to maybe even 10 years ago, as far as
people, hospitals allowing family members, husbands, siblings in many instances, to actually be present for the delivery.
And Dr. Nuppel adds, the LDR offers one more important benefit.
Most importantly, they're awake, they're alert, they have the ability to make some decisions on their own. They're more involved, and generally that makes for a happier patient and a better outcome.
We came in Monday night, we delivered on Tuesday morning, it's Wednesday afternoon, and Don hasn't been home since. You know, so it really helps with the family bonding.
I've been a part of it from the start. I mean, instead of waiting to come home and settle in, we've settled in right here in the hospital.
LDRs have gone a long way towards making maternity care more home-like. But there are other systems outside of hospitals that have always made that their mission. This is the Maternity Center, housed in a turn-of-the-century townhouse in Manhattan. It is a freestanding birth center, surprisingly less expensive, and a much different choice for childbirth than the hospital we just saw. There are 150 such centers around the country. Everything from prenatal care to classes to the birth itself happens here, with the assistance of nurse midwives. Dr. Ruth Lubick, a certified nurse midwife, started this center in 1975.
I think that what a freestanding center offers is one end of a continuum of care. And I am certainly foursquare behind humanization of hospital care. And I think the LDRPs do that. And it's really, I think, a great tribute to what the nurse midwives have been able to do in the sense of demonstrating the kind of care that gets response from families, which we did in freestanding birth centers.
Geraldine Scazzaro will give birth here in 3 months. She's already had one child at this center.
The reason we love the midwife, the maternity center, is I think probably the primary thing is personableness. And I'm directly involved with the birth. My husband's directly involved with the birth. This is the most horrible part.
Women here also are directly involved in their prenatal care. Marcy Tardio, one of the midwives, describes the reason.
And by having the chart available to the woman, and she gets to write in her chart and read what's written, I think that we end up having a more joint effort, and women do feel a sense of empowerment in being responsible for themselves and their own care. You know, one thing that you can do if you're concerned with that is just keeping a little journal of what you're eating on a daily basis.
What goes on in the prenatal period is very important because you get a real sense of who's anxious about this, what kind of additional supports this mother, this family may need. And it's that kind of interaction that goes on and monitoring, which goes beyond the, yes, your urine is fine, yes, your weight is fine.
Do you know if it's a boy or girl yet?
No.
A hallmark of birth centers is the importance of families.
And many children will be in attendance at the birth itself. They really rise to the occasion. It becomes a wonderful experience that doesn't provoke fear if they're well trained, and we do give sibling classes.
A lot of people ask us about safety, but I feel much safer in the hands of a midwife than a doctor. Just because my experience has been that in the maternity center, it's one, maybe two people that you're directly involved with, not only for your own whole prenatal care, but then the whole birthing experience. It's you and her and your husband.
It's not the right place for every woman. The families do need to be screened for health. But if you institute a screening procedure, if you have a good backup connection, there is no evidence whatsoever that a birth center is less safe than is a hospital for normal childbirth.
This is how they take the blood pressure.
Like Geraldine, a growing number of women across the country are requesting midwives for prenatal care, labor, and birth. Responding to the market, hospitals like Robert Wood Johnson have added nurse midwives to the healthcare team.
Our institution decided to develop a midwifery program mainly because of consumer demand. There's a significant group of people in the community who want that experience. I think that the time that they spend with a patient throughout their pregnancy and the time that they spend with a patient during their labor and delivery is essential.
Professionals agree that all women need a lot of information during pregnancy. So, whether midwife or obstetrician, in or out of the hospital, good care begins with a specific list of the woman's needs and preferences.
And most importantly, I think for their overall experience, they should be able to elicit a list of their requests that they think are important for their experience. And that list will probably alter as they go through prenatal classes and learn more and more about the childbirth experience.
And if there's anything that they feel uncomfortable with or that they really are opposed to, that it's extremely important to discuss that with their health care provider prior to the fact that they're coming in labor.
So in essence, it really comes down to communication between the health care provider and the patient or client. That interaction is critical to a very good outcome.
Communication between provider and client, asking questions. Many women ask their physician, how can they be sure that the fetus is okay, that there are no hidden genetic or developmental problems? In the next couple of minutes, we are going to describe 2 prenatal diagnostic procedures that are used for this purpose. They're called amniocentesis and chorionic villus sampling. Both can determine the fetus's sex, but more importantly, the presence of genetic disorders such as Down syndrome, cystic fibrosis, and sickle cell anemia. Both tests, which are generally offered to women 35 years and older, require the use of ultrasound, a procedure that creates pictures of the fetus. It was originally developed to measure the fetus, check its heartbeat, and confirm its age.
Hand over the head.
For amniocentesis, ultrasound locates the placenta so that a slender needle can be inserted through the mother's abdomen and into the amniotic sac to withdraw a sample of fluid. The cells in the fluid are then tested for genetic disorders. Results are determined in 2 to 4 weeks. Amniocentesis is usually done 14 to 18 weeks into a pregnancy, sometimes as early as 12. Similar to amniocentesis, but able to provide the pregnant woman with earlier results, chorionic villus sampling is performed 9 to 12 weeks into the pregnancy. As in amnio, a needle can be used for CVS, or if the mother and her doctor prefer, a very thin tube called a catheter can be inserted into the cervix and guided up into the placenta. A small sample of cells is removed and then tested. Results are determined in about 10 days. Rates of complications are low. For amniocentesis, about 1%. For CVS, between 2 and 3%. However, both procedures are invasive, and pregnant women should discuss pros and cons with their providers. So far, we've looked at how hospitals are responding to families' wishes. We've heard Delilah Amelbear say she wished she had more information about what happens during pregnancy. In the section that follows, called Making Choices, our co-host, Dr. Frida Lewis Hall, inquires into these matters. Her guest is Dr. Phyllis Leppert, chairperson of the Department of Obstetrics and Gynecology at Rochester General Hospital, a professor at the University of Rochester, and a certified nurse midwife. In their conversation, Dr. Leppert began by distinguishing between nurse midwife and obstetric points of view. Midwives, she said, focus on and treat pregnancy and birth as normal physiological processes, while physicians are trained to look for any medical problems and to take care of women who have such problems. Now, Dr. Lewis Hall continues by asking about detecting risk in pregnant women.
Who decides that a mother is at high risk or low risk?
Well, I don't like the term high risk and low risk because I believe that it's kind of a continuum. And what all people try to do on the healthcare team, nurse midwives and doctors both, is to minimize the risks as much as possible. But there are a number of scoring systems, if you will, that we use in obstetrics to determine whether certain patients, certain women are going to have potential problems with the pregnancy. Things such as a history of diabetes in the family, mothers who are over 35, teenagers.
It sounds as though if you're low risk, then a nurse midwife might be the right person for you to see. And if you're high risk, then perhaps not, and then an obstetrician would be the right person. Am I reading that right?
Well, to an extent, but I would go further than that because I think you have to understand that the nurse midwife is going to do midwifery management for patients that are within the normal range. If problems develop, then the management of a problem becomes what we call co-management, where the nurse midwife and an obstetrician will work together. And then there is something that we call medical management, where the nurse midwife will refer the patient to the care of a physician completely. But that doesn't mean that the nurse midwife can't be with the person or the mom. She might go into the hospital with her and be there at the time of a problem that really was a true high-risk problem.
So the idea that that scares many mothers, that, well, what if I start out low risk and end up high risk? What happens to me? That gets answered by this practice in the continuum?
It's a team. The nurse, midwife, and doctor are a team.
Now, this sounds like a lot of decision-making is going on. Who should be a part of that decision-making process?
I think many places in the United States, and certainly we're doing this in Rochester, of having classes called preconceptual classes or pre-family classes to talk to families about their options, what they need to do to make sure the pregnancy is going to be a good one. And that's done by nurses, by the nurse midwives. Physicians also are encouraging young people to do this. I think, however, it's important for the family to know that whoever they see, they have to talk to them about what they wish, the kinds of things that they want, who they want to be with them when they give birth, how much medication they may want. Everyone wants a normal baby and a normal mother and a happy outcome. And so it's developing a partnership. And the family has to be comfortable with their provider, and the mother has to be especially comfortable with that provider.
Now, we're talking about a number of factors here that determine risk. Is there anything that a mother can do or ought to do to help manage her own risk?
That's a very good point. I think it's very important for mothers to take responsibility for themselves, certainly even before they contemplate a pregnancy. And that would mean that they would pay attention to their diet. They would make sure that their weight is as normal as possible, that they're not in an environment where they're going to be pressured